Thank you for the introduction. Actually, it's not a case of cervical cancer, but vulvar cancer. And it's a very special case of a modified posterior pelvic exenteration with a special reconstruction operated by Professor Murlem in our department. I have no conflicts of interest to declare. Oh, sorry. And yeah, this is about a 53-year-old patient who presented in our department with a vulvar tumor, intermittent rectal bleeding and obstipation for some months. She had a medical history of chronic obstructive pulmonary disease and appendectomy some years ago. And on pelvic examination, a 4 by 3 centimeter large exophytic tumor was seen on palpation. There were clear signs of vaginal infiltration, rectal infiltration, and large infiltration of the perineum, and the tumor was estimated to be 9 by 5 centimeters.
Great. I'm really happy to be at this conference, especially a gyn-onc conference or a session so focused on surgery. And I think many of the themes I have heard already spoken, as well as the themes spoken yesterday at the ovary course, I think will be reflected in the talk. And so I'll talk a little bit about our practice, but mostly show some cases that we use orthopedic surgery in collaboration with gyn surgery to really affect the best outcomes. So we kind of know the tradition, right? Like if we have, I'm going to be really talking about recurrent cancers, but some of these principles, of course, can apply to primary disease that's isolated. But when we think about recurrent cancers, we know, and this comes up every study, every retrospective study that is published shows that long disease-free interval matters. Oligometastatic disease, we had a great talk about like, what does that really mean? Someone who has a good functional status, it doesn't really matter if we can, right? I think most of us.
A lot. I speak a little faster to bring the time back. Complex reconstruction. We have a lot of complications during gynecology treatments, and we have 3 borders. If you make vaginal treatments, you have the most complications under the arteria uterine till to the arteric uterine around it, then this is mostly complications after benign, like laparoscopic hysterectomy and high vaginal treatments. And after oncology cases, the most complications of the ureter will be till to the crossing of the iliac border. What is the main problem? What you find it? First, you see the paralytic ileus. Why? If you have a defect inside of the bladder or of the ureter, it comes the urine. The urine makes every time first symptom paralytic ileus. And then you will find it also creatinine in the drainage, sometimes also a little small.